Well, I prepared the presentation in English because, as I said, I think it's better now if we have people from different countries. So, well, first of all, thank you very much for the invitation and to share here our experience using clinical decision support systems on children with congenital heart disease here in our hospital in Sant Joan de Déu. Let me, because I have here, I cannot move now. So first, let me start with a brief introduction to put you in context. So congenital heart disease is the most common birth defect that affects about 1% of live births, which represents about 100,000 newborns in Europe each year, and is the leading cause of neonatal mortality in developed countries. So advances in its diagnosis and treatment have significantly reduced childhood mortality from congenital heart disease, and now we have over 90% of survivors into adulthood. However, this improved survival has increased in hospital and also out of hospital morbidity, which also exponentially increased the healthcare costs and the caregiver burden. Moreover, these pediatric patients with congenital heart disease are at increased risk of clinical deterioration, either due to their underlying disease or the surgery that they need to take in order to correct their disease. So what happened also is that currently this clinical deterioration is detected in most of the cases when it has already occurred. And this, of course, has a huge impact on the long-term outcome of these patients. So we are dealing with a pediatric disease that has a major health and also social impact. So it's a complex disease that has also a complex treatment process, and also is associated with a lot of comorbidities. For example, we know that 30% of children with congenital heart disease in the future will have attention deficit problems, hyperactivity, and low academic performance. The second thing that we are facing here is that the patient and family-centered care is not standardized. So this means that we have low ratios of health professionals per patient, which causes extra working hours. And the third thing important here is that also we have an inadequate reimbursement system that is based on the episode rather than on the value. For example, we know that congenital heart disease represents only 4% of the hospitalizations, but it consumes more than 20% of the health resources, which demonstrates these huge impacts in our healthcare systems. So these pictures illustrate here the typical journey of the patient with congenital heart disease. So usually in developed countries, congenital heart disease is detected in fetal life by means of a fetal echocardiography, and depending on the complexity of this congenital heart disease, the delivery is then planned in a tertiary center like our hospital. Then, when the baby is born, he or she might need a palliative intervention, for example, before the surgery, or might need to stay some days in the neonatal ICU until the corrective surgery can be performed. Then, depending on the complexity of this congenital heart disease, this baby might need more than one surgery to correct their defect, and therefore spend from some days until several months in the hospital, depending also on the different complications that this baby might have to deal with during their whole stay at the hospital. Then finally, when the baby is discharged, this will need to continue doing several follow-ups in the hospital with the cardiologist during the entire life. So this clearly illustrates that congenital heart disease is a complex disease with a huge impact on our healthcare system and also on the patients and their families. So the cardiologist department here of Sant Joan de Déu Hospital, which is led by Dr. Sánchez de Toledo, has been working during the last 2 years to improve the care and the quality of life of these patients during their whole hospitalization by means of developing innovative solutions, trying to provide a personalized treatment, minimizing the occurrence of adverse events during the stay at the hospital after a cardiac intervention. So this is why in 2020, the Hospital Sant Joan de Déu launched the Cortex, which is a control tower, like the ones that you can find in the airport. So basically from this control tower, we can monitor, we can control everything that happens in the hospital. So this space is made up 3 different areas. So first we have the command center, which is an area that is designed for collecting and analyzing information based on the principle of efficiency. So in the command center, we can monitor the evolution of emergencies, for example, the hospitalization flows, state of the intensive care unit, surgery block, etc. Then the second area that we have is the contact center, which is a multi-channel service that is oriented towards a proactive and personalized care. So in this area, we have different healthcare professionals that are in continuous contact with patients and their family by means of phone calls or also by emails. And finally, we can find the e-care. And e-care is a remote monitoring center where professionals remotely monitor children who are admitted at all times, wherever they are, in the room, walking around the hospital lobby, or playing in the playground. So this initiative has made it possible for babies with congenital heart disease who previously has to be kept under observation in the ICU to be transferred to a room with their mother with a small connected device that analyze their evolution at all times and also alert the professionals if their conditions worsen. So as you can see here in this picture, e-care is operated by a multidisciplinary team that is formed by biomedical engineers, pediatric cardiologists, data scientists, informaticians, that we work all together trying to develop predictive models for the risk of clinical deterioration in children with congenital heart disease. So if you allow me this an analogy, e-care would be like the telemetry center in Formula One, where the different signals are being analyzed real time to make decisions, fast decisions. But instead of being signals from the car, we work with vital signs from the patients. So one of the novelties of our project is that we start to monitor the babies while they are at the hospital ward. So as you can see in this picture, with a small device of the size of a smartphone, we can monitor the vital signs of the patients, which includes the heart rate, the oxygen saturation, and the respiration rate 24/7. So this allows the patients to have freedom of movement, to take a walk, for example, or go downstairs to play in the playground, while they are still being monitored. So this initiative has been very well received by the families because it has improved the experience of the patient and also of their families. So apart from allowing them greater mobility around the hospital, this monitoring system also has slightly reduced their state in the ICU, as you will see later. So what we are now currently working is trying to expand this, and we are going to start monitoring also patients with complex congenital heart disease while they are at home very soon. So all the data that is being captured by this small monitoring device, together with other clinical data from other devices, for example, the one that we use to measure the blood pressure or the body temperature, and together also with clinical data from the electronic and medical records, this data is sent real time to the Digital Smart Center. So there, with all this data, what we did was to develop a Cortex e-care traffic light, which is a patient stratification score of the risk of clinical deterioration. So then this risk, this score, is then rated via a traffic light scorecard with 3 different colors. So we have green. Of course, here green, we cannot use it, it is white, but you can see the letters here in green, and means that the patient is stable. Then we have yellow. It means that the patient is starting to be deteriorating. You need to pay attention to them. And then red, which means that the patient is unstable. So this Smart Central is visualized in the e-care center, allowing optimal decision making. So how this Cortex traffic light score? Well, very briefly, the current version that we have of the traffic light score used 7 different variables, which also includes, for example, the age of the patients, because as you might know, so the vital signs change a lot with age. It's not the same, for example, the heart rate of a neonate that could be 120 than the heart rate of a teenager that could be 60, like an adult, no? And also the additional variable that we also use here is the cardiac physiology, that we have 2 different types, which is univentricular or biventricular, which these have an effect or an impact of the oxygen saturation of the patients. This variable currently has to be introduced manually by the clinician in the system, but now we are working together with Ascom in order to automatize this part. So then what we have is all these variables feed a rule-based algorithm, very simple, that gives 0, 1, 2, or 3 points to each variable, depending on its value. Then this final score is calculated as the sum of all individual scores. And finally, we plot the final score with 3 different colors, as we saw before in our Smart Central. So our preliminary results during this first 6 months of this pilot study, we already saw a significant reduction in the average length of stay in the ICU and also in the total length of stay of the hospital, which of course have an impact also on the operative cost of the hospital by reducing about 1,000 euros during this period. So what we are currently working is on adding more variables to the algorithm, variables, for example, from the laboratory tests, medication, as well as other clinical variables that are related with the surgery and that clinicians think that are very important. We also aim to use explainable artificial intelligence-based methods in order to integrate all these variables and provide a meaningful and accurate prediction of the risk of deterioration in these pediatric patients with congenital heart disease. So we are doing that in collaboration with other hospitals and also different companies within the setting of an European project that is called Accelerate. So let me show you some preliminary results of the first year pilot of our project. So during this first year, a total of 254 pediatric patients with a total of almost 300 episodes were monitored during this year. So of the total of these patients, 41, which represents about 60%, experienced one or more adverse events on the ward. But only 8 of them were followed by an unplanned ward to ICU transfer, which means that only 8 had severe adverse events. So in this table, what we show here is just the clinical variables of the different populations. And as expected, of course, in the group of the patients that have an adverse events, a severe adverse events that have to be transferred back to the ICU, the age was smaller, so they were younger patients, and this is normal. We know that the neonates are the ones with a higher risk of complications. Also, as expected, we see in this population that they have longer length of stay, but also the percentage of patients that have a cyanotic congenital heart disease is higher in this population. But then, what happened with our Cortex traffic light score if we compare these different populations? Where what we saw here is in this graph is that the average Cortex traffic light score of those children who experience an unplanned ward to ICU transfer, so a severe adverse event, was significantly higher compared to controls, which is the group of children who didn't experience any adverse events at all, even 4 hours before the adverse events. So what this graph illustrates is that instead of using the actual value of the score, what gives you a lot of information is, for example, how many times the patient was in red in the last hour and compared to the previous hour. Because if this time is increasing over time, as you can see here, so we look 8 hours before the adverse event, you see that this score is slightly increasing until it becomes significantly different from controls. So then just a very preliminary study that we did also was to see whether this score also can give you information about the readmission. So what happened with that patients that had to be readmitted in less than 30 days after discharge due to an adverse event related to the previous surgery, because maybe the patients can be readmitted because they have a flu, for example. This was not considered here. So what we saw in this small population also is that the Cortex traffic light score between 7 and 12 hours prior to discharge also was significantly higher compared to controls, which means that by using this score, maybe these patients will not be discharged, maybe will remain in the hospital, okay? So just as a summary, just to finalize my presentation, this is an overview of what I said, what we are working now. So we are trying to integrate more variables from images, from laboratory, from medications, and also using explainable. So this is very important. As I say, explainable, because if the algorithm is not explainable, the clinician will never trust this algorithm, okay, in order to predict this risk of deterioration in pediatric patients with congenital heart disease. So thank you very much for your time, and I'm happy to answer any questions you might have.
Okay, thank you so much. Okay, so any questions from the audience? Perdão. Peço desculpa. Algumas questões que queiram colocar à Patrícia enquanto ela está em linha? Algumas questões? Ok. Uma questão, Juan Carlos Herrero, e outra questão aqui.
Hello, Patricia. Thank you for the explication. In what accept the system the another personnel of the hospital? The people say that you are very new and they don't like the system, or the people believe in the project?
Sorry, can you repeat, or maybe you can do it in Spanish if you want.
No, digo, la gente del hospital, ¿cómo acepta el sistema? ¿Lo valida? ¿Cree que está todavía con una evolución muy grande, o cree que es algo que puede, creen vosotros?
Yeah. No, they believe in us. If not, I'm in a trouble. No, so now the system, so they know that the system is, as we said, is in the gym. So we are now capturing data, because, you know, to build this kind of models, we need a lot of data. And as you see here, the numbers that we have is not so big. So the percentage of patients that have something is so likely for them is very low. So and they know that this has potential, because with these preliminary results that we show, they know that they have potential, but we are not currently using the current version of the algorithm to make decisions, because, as I said, we are now trying to improve. And one of the things that we want to implement now is, as I said, is this tendency thing. So instead of plotting the value that is updating every minute with new variables, it's just to calculate the average score and to compute the tendency. But this might give you more information about the tendency of the patient, and might the clinicians start using this. Any more questions? I don't see your faces, so I don't know whether...
Patricia, ¿puedes dejar de presentar? Que así vemos
¿Sí?
en la videoconferencia.
Vale.
Eres tan amable. Gracias.
A ver si encuentro, porque esto está minimizado. A ver, aquí. Perfecto, ahora sí que os veo.
Hola, buenas tardes, Patricia.
Buenas tardes.
Me ha parecido muy interesante y quería preguntarte si este sistema se ha desarrollado también en pacientes, en niños ingresados en unidades neonatales, en NICUs.
No, pero estamos... O sea, hola, encantada. Gracias por la pregunta, es súper interesante. El piloto que hemos hecho es en planta, pero de hecho actualmente ahora estamos trabajando en la implementación de este sistema, evidentemente cambiándolo un poco, porque en la UCI, por ejemplo, los niños pues muchas veces están conectados a un respirador, con lo cual aquí las variables ya cambiarían un poco. Pero sí, estamos trabajando en adaptar este score y otros. Tenemos otros score, por ejemplo, para predecir sepsis o la bronquiolitis, también en las UCIs neonatales y pediátricas.
Any more questions? Mais questões? Peço desculpa. Isto é um evento multilíngua. Mais questões? Patricia, pues te despedimos con un gran saludo de corazón, un aplauso.
Muchas gracias.
Patricia, que veas que